Beautiful. I enjoyed the music. I remember those 12-hour shifts, everybody. And, I really, want to say that I, first off, want to thank every single ER doctor, frontline, first responder, ER nurse, paramedic, ICU doctor, ICU nurse for, really going through COVID with honor and dignity and grace. I will admit to having survivor guilt for the first part of COVID as a former ER doc who retired only because of my own blood pressure issues and stuff like that. But those of you that are still out there doing your thing, even to this day, you have my utmost of respect. But the 12-hour shift is a hard thing, man. And, once again, those songs were meaningful to me. Anyway, listen, it is an unbelievable honor to welcome everybody here tonight it's just an unbelievable event personally for me, a culmination of a dream that I had that we'll tell the little story when I introduce Sherry Yafai, my co-host for the evening. But I did 33 years in the emergency medicine business, everybody. I actually started back in 1981. Back at Mount Sinai Medical Center in Cleveland, Ohio. Don, why don't you go ahead and throw that first slide up there? And listen, I love my career. When I started in emergency medicine, there were literally only 7 residency programs in the entire country. And, emergency medicine was brand new at the time. I'll always remember my dad saying to me, "God damn it." Oh, and we can curse on this, guys, I think. And listen, I have such great partners tonight. I have Dr. Lynn Lassiter with me and Dr. Yafai. One of the things I love about my female ER colleagues is that they're always bawdy, right? And Ira, I know, for sure has got a lot of things going on in Canada these days. So feel free to let all out tonight, guys. But, my point is it's such an honor tonight to join everybody together because, the ER world is so unique and I was honored to be able to go to work every day in a career that I love. But what I was leading to is I'll always remember my dad saying to me, "God damn it, I didn't send you to med school to go work in the freaking ER." Okay. Because back then it was viewed as kind of the dregs of medicine. And, if you couldn't get another job, you worked in the ER or family practice doc. I know Jeffrey Hergenrather remembers those days, of course. But, the point is we had to fight. We had turf battles. We literally had to ask the radiologists or the surgeons if we could even order a CAT scan at that time. So I was a pioneer then, and I feel like I'm a pioneer now. After my emergency medicine career, which I loved, I've developed a medical cannabis practice here in Venice, Florida that I'm proud of. And I currently service over 5,000 patients in the medical cannabis program. But it's really not about numbers as far as what's going on in the medical cannabis world. Got any of those slides up, Don?
Right now we're on the why. So you're picturing the ER. So you can't see it.
The why, okay. So I can't see him. I got it. So the why is interesting. So why am I so passionate about what I do now in my medical cannabis practice? And I always start my lectures by telling everybody that I'm a social scientist first. I'm not a science scientist, and that's why each of my guests tonight are going to have a few slides, but we're not going to overwhelm you with slides because I know better. We're ER docs, okay? We want to know what we want to know. We don't want to be overburdened with idiocy, right? To me, when they brought the review of systems to an emergency medicine chart, they made liars out of each of us every single day because who wants a full review of systems? Nobody wants a full review of systems, right? But my point is, in the emergency medicine world, okay, what I learned is this: there's 3 things that nobody's ever going to do in an ER. Personally, I never did. I never put a tube down anybody's throat, okay, over a cannabis overdose. And Dr. Hergenrather is going to explain that when we talk about the endocannabinoid system. And it'll be talked about again and again, but it's the safest. The only way you die of a cannabis overdose is if you're smuggling it out of Vietnam and a bale of it hits you in the head and breaks your neck. Right. The second thing is I never took care of a couple, right? Husband and wife or domestic partners, whatever they may be, who had smoked a joint together and beaten themselves up afterwards, right? That's alcohol, right? So we all know that alcohol is acutely and chronically disastrous in every ER. right? But in my world, I never saw a cannabis overdose because in my ER career, edibles weren't out yet, right? So nobody was going to eat a pan of brownies in Alliance, Ohio, and come into an ER as their first cannabis exposure. But now with dabs and concentrates and edibles, of course, that'll happen in ERs. But the point is, everybody goes home, you know. And then the third thing is I never lost a friend or a friend's kid or a partner to cannabis. I've lost them to drugs, alcohol, women, gambling, tobacco, and every other thing, right? So to me, I came in as a social scientist knowing that cannabis as a substance had never impacted my ER world. And in fact, I know many, many people, other doctors, lawyers, bankers, you know, people much smarter and more successful than I that had used cannabis throughout their adult careers, but of course had to fly under the radar because of all the job and, you know, and otherwise restrictions, which we're going to talk about in the chat tonight. And Don, we have that last slide, right? And this is what I really want to lead into with Dr. Hergenrather, and I'm going to go ahead and introduce him first. There's three things that every patient wants, and I literally start every patient visit in my medical clinic now, my medical cannabis clinic, with this. They want to feel the best they can. They want to do it in the safest, most natural, most plant-based way that they can, and very importantly so, in the most controllable way that they can. Cannabis uniquely is able to be controlled by patients, right? The vast majority of them. Whereas alcohol, of course, narcotics, Ambien, Ativan, Xanax, gabapentin, Lyrica, you can't name any of those that don't ultimately end up controlling patients, right? And the third thing is to be legal, right? In doing so, everybody deserves to be legal in doing so. And that's why we have such an unbelievable panel tonight with Ira Price, who's coming to us from Canada, that is now a legal adult use country, right? Dr. Yafai and Dr. Hergenrather, who are out in California, although Jeffrey's out in Hawaii today, and he'll tell us what's going on out there. But once again, different. And of course, David Knox, you know, who joins us from Oregon, right? So everybody's got a different thing going on in their state and or country. So it's very unique about cannabis, but everybody deserves safe, legal, regulated, and I say educated access to medical cannabis. So those are my opening remarks. And listen, I'm so psyched to have this panel. I got to tell you, the fact that I could gather this panel is very humbling to me, and I mean it. And I want to introduce Dr. Hergenrather first. Dr. Hergenrather was an early mentor to me, and I met him at AMPA. No more discussion about that organization tonight will be had. And there's some jokes behind that for those of you that are in the inside. But anyway, I met Jeffrey at, long ago, back in 2017. He came to Florida to present at one of our first cannabis conferences here in Florida, quickly became a mentor to me, and I've kind of latched onto him. But more importantly, he is one of the founders and the immediate past president of the Society of Cannabis Clinicians. Dr. Yafai also sits on the board. And just to speak to my extent as a general member, in my opinion, there is no better organization nationwide that does physician education and advocacy in medical cannabis. So it's such an honor to have him joining us tonight, both personally as a mentor to me and professionally, because, you know, I just don't think there's any other OG in medical cannabis education more so than Dr. Hergenrather. Now, I actually reached out to him just to get some opinions on who to get. I didn't know that he actually did 13 years of emergency medicine himself before he went into medical cannabis. So he qualified for the evening, because you have to be either a current or former ER doc to present tonight. So Jeffrey, without further ado, it's an honor to have you here tonight to give us kind of the general overview of the endocannabinoid system and a little bit about Society of Cannabis Clinicians as well.
Thank you, Barry. Thank you very much. I'm honored to be included in the panel today. I do want to just reach out and thank Barry for his inspiration and his crew, Don and others behind the scene, for putting this together. It's not without a lot of effort that this comes together. So my thumbs up to you guys for doing that. I don't know where you picked 13 years out, but I'm going to add another 13. I was 26 years in the ER, for what that's worth. Ended my ER.
Oh, it's Bonnie Goldstein, actually, Jeff, that had 13 years. That's what it was, right, Sherry? Bonnie had the 13. 26.
Well, 13 from Bonnie at LA County was worth 26 by my guess anyway. So I'm going to just move on to share a screen and show you some things that I think would be just good things to think about. So the turf of the ER doc, I've always found it interesting to recognize that the docs that I first ran into in cannabis medicine were predominantly emergency docs. There was a couple family docs, then a psychiatrist or two came along, but the ER docs have always been kind of within the backbone of this group of docs that are comfortable with emergency medicine. And I think it kind of speaks for our independence, our free thinking, our wish to not be pinned in and controlled. And honestly, ER medicine has changed a lot since I was there over 20 years ago. But moving on, this is just a brief bio. I had my undergraduate work in Berkeley. I went on to Brown University for the medical program there, where I got my degree 5 years later. I did have 1 year of rotating internship in the South, down in South Carolina. And then I was just hot to get into practice. So I started both as a general practitioner and as an ER doctor in Columbia, Tennessee. And I kept up my ER work for those years that I mentioned. And it was really a nice lifestyle raising a family with 4 kids. And we had 4 kids in 4 years. My wife and I have been together for 50 years. And all our kids live in the same hometown, and we get to be around them and our grandkids. So it was really a good quality time raising my kids. I went into a cannabis consultation practice after the law was changed in California in 1996. So I started doing my first few recommendations for cannabis in 97, and then really opened an office and took it on earnestly in 1999. So I've had that practice going for 22 years now. And just in brief review, over 3,500 patients. I know a lot of docs, having practiced that long, might say they've had 10 or 15,000 patients, but I kind of prided myself in the idea that I was gonna spend some quality time with patients, listen to their story, listen to their heart and lungs, take their blood pressure and measurements, treat them like like I was a general practitioner, which I was. And I still today find patients hanging on to my service because their doctor has never touched them. Their doctor has never done a blood pressure, never listened to their heart and lungs. They'll refer out to appropriate specialists if you give them enough of a story. But as a doctor who actually lays hands on and listens to their patient, that's what I do. So my initial visits are usually an hour, sometimes more. And I just like that way of practicing medicine. What can I say? And then this list of common diagnoses that I see in my practice, it really includes everything from infant care all the way to end of life care. But these are the most common presentations as far as my practice has been concerned. You should all know, and if you don't all know, this endocannabinoid system is throughout the animal kingdom. And by the nature of some of these creatures that have genes that are indicative of a cannabinoid receptor, we know that this natural cannabinoid system has been evolving along for something in the order of 600 million years. It is important to survival because of the things that it does for us. It's an on-demand system. It helps us to eat and to drink and to relax and to sleep and to forget, and protective roles, lowering blood pressure, lowering intraocular pressure, a number of things that it does, anti-inflammatory roles and so forth. I didn't bring the whole list, but it's a bronchodilator. So even those who are smoking cannabis, or probably better yet, vaping cannabis, they're going to find an expansion of their lungs, an easier effort to breathe. If you really have pulmonary disease, I'm gonna recommend that you don't smoke, but people do, and I don't hold that against them either. So I think it's important to be open-minded as a cannabis doc as to the way people choose to use it. I think this is rather telling. If we think about the cannabinoids, the natural cannabinoid here being anandamide, I don't have an image that is of 2-AG, but the 2 dominant cannabinoids in our body, the endocannabinoids, the matchup with THC is rather remarkable and rather telling to the idea that, okay, I get it. THC fits into the CB1 receptor. It directly activates the CB1 receptor. It does the things that the natural cannabinoids do, and kind of in spades. It's a powerful cannabinoid. It's very potent for anti-inflammatory roles. As people will understand from their experiences with their patients, doing a dab and getting a huge dose, you can get so much vasodilatation in a moment that you'll faint away. And sometimes people have really hurt themselves from falling after dabbing because of the potency of the THC and the massive dose they get with one toke. But I think it's important to recognize that THC is a direct CB1 agonist. I want to take a moment to also say that there are two cannabinoid receptors we commonly talk about, CB1 and CB2. There are probably something around 23 or more cannabinoid receptors in the body that respond to the endocannabinoids or to the plant cannabinoids. And we have to keep that in mind, that it's not just a narrow field. This is a broad area. So we not only have a lot of receptors, we have a lot of precursors of natural cannabinoids that probably play a role. Meshulam thinks that they play a role in our personalities. So here we're talking about over 100 different molecules that are precursors to cannabinoids that probably affect the way that we behave. Moving along to the next topic, this is just an image of what these CB1 receptors look like. The CB2 is also shown as an amino acid sequence on your left side of your screen, the CB1 being the blue dots. The mobile CB2 population is a little smaller molecule, and it's, they are made down within the, at the ribosome. They migrate to the cell surface where they set up shop, somewhat like this is represented in this dark zone in the cell membrane. That's where the action is in the cannabinoid receptors. It's there in the cell membrane, ready to receive not only the endocannabinoids, but the plant cannabinoids as well. And this tail that we have on the endocannabinoid molecule, on this CB1 receptor molecule, has a lot of influence as to whether the expression of the activation is really felt or not. So the work by Pat Riggio and others at the NIH have gone to a great degree of understanding of the way this receptor is modulated. It's not just black and white, on or off. It's much more complex than that. So moving along, I wanted to go on to the fact that not all the cannabinoids, endocannabinoids work the same. Not all of our CB1 system works the same. As we look at the genes, it's rather remarkable to note that there are clusters of these endocannabinoid receptors that fit different conditions. So moving along to the next slide, this is one of 2 pages of conditions that are implicated as a cannabinoid polymorphism, a little difference in the cannabinoid receptor. So those with schizophrenia may in fact have a very similar looking CB1 receptor. And those that suffer from migraines similarly may have the same receptor. MS, Huntington's, Parkinson's, irritable bowel, and so forth. This may be where a lot of the inheritance of diseases come through, is actually by way of differences in our CB1 receptor population. Here's fibromyalgia, which we otherwise have a hard time understanding. Dunnett has shown that the CB1 receptors are similar in people with fibromyalgia. Again, perhaps giving an explanation for that. And then to the second page of this, we've got mental symptoms that may include endometriosis, seizure disorders. Matsunaga in Japan showed that happiness was also had a similar endocannabinoid CB1 receptors. In this, with this way of describing a CB1 receptor, he tested a bunch of people, those that were just effusive, happy people, they have a similar CB1 receptor. I think that's fascinating, and I don't think of it as a deficit, a CB1 receptor deficit. I think as simply a difference. Here's depression. alcohol dependence, obesity, ADHD, PTSD, different lipid profiles and other conditions, right down to cyclic vomiting syndrome, which I think we're going to learn more about as we go along this evening. So I find it really fascinating that we have such subtle differences in our CB1 receptors that may manifest as a likelihood to develop these various conditions. So if a patient comes in and they've got a strong family history of, let's say, mental illness in dad or mom or themselves, I'm going to try to make them comfortable in understanding that this is inherited, perhaps through your CB1 receptor, and that, well, I did a paper this past year on ADHD, and you'll find it in the literature. And one of the things in the neuroscience that I found fascinating was that the very deep structures in the brain, in the limbic system, and in all the way to the cerebrum, there are pathways that are overactive in people with PTSD, with some of the depressions, anxiety, with ADHD. These are really busy circuits that don't calm down very well. They may have glutamate neurotransmitters, and they also may have GABA neurotransmitters, but in general, they don't quiet down with activation of the CB1 receptor very well. So they stay kind of lack of focus, hyped up, busy, confused, lack of being able to get along with people, with jobs, and with partners. So I find that really fascinating to understand that these same receptors in these mental conditions, when activated by THC, are calmed. And it really gives a patient a lot of comfort in knowing that here's cannabis providing an augmentation role to their natural cannabinoid system to make them feel better. And they shouldn't beat up on themselves thinking they're addicted or something. This is just normalizing their systems. So I like to make patients comfortable with the idea that even regular daily use is fine and appropriate if they have the condition that requires that. You probably have all seen this, but it came out of NIH, 8 years ago now. Modulating endocannabinoid activity may have therapeutic potential in almost all diseases affecting humans, including obesity, metabolic syndrome, diabetes and diabetic complications, neurodegenerative, inflammatory, cardiovascular, liver, gastrointestinal, skin diseases, pain, psychiatric disorders, cachexia, cancer, chemotherapy-induced nausea, vomiting, and many others. Packer and Kunos are not pro-cannabis. They are researchers, and this is just a fact that they recognize that activating the endocannabinoid system or modulating the endocannabinoid system, which we as docs are commonly doing with cannabis, and these docs are looking to the pharmaceutical industry to bring us new drugs that would interact with the endocannabinoid system. So this is something that we should be aware of. We can help patients with all kinds of conditions if we listen carefully and help fashion a treatment plan that works for them. So I'm going to have to wrap it up here in a minute, but I want you to understand that you got an introduction to the Society of Cannabis Clinicians from Barry. I do appreciate that. You could simply go to cannabisclinicians.org and see the website and go to those parts of our site that are free, which includes some videos and a research library. So if you're intent on discovering more about any particular medical condition, you will find that the papers we've selected are worthwhile in researching those medical conditions. So we are an international organization. We've got membership from all over the world now. We've recently updated our series clinical training curriculum, and this is a really state-of-the-art educational system, and I think you'll find it really valuable. You can sign up for individual modules or get a group module of 5 or 12 courses, and I think it's a really worthwhile way to go. For members of the SCC, you're entitled to a 20% discount. We have free access to quarterly presentations by experts. We have a monthly journal club that some people find really helpful to keep up on the literature in cannabis science. We have some private online member forums where you can post questions and communicate with other cannabis specialists. We have a place where, as a practitioner, you can be on the world map. So if people are trying to find somebody in your geographical area, you can be found there as a cannabis specialist. We've got newsletters, case reports, and other benefits some of which I already mentioned. So that's really all of my slide set. I really appreciate the opportunity to say these things, and really encourage you that cannabis medicine changed my life, as from a GP through an ER doc to a cannabis specialist. There is no more appreciation from patients than having somebody that understands and can guide them in cannabis medicine. Thanks so much for the opportunity. I'll drop out of my share screen mode, I think. I'm trying to find that here. Yeah, there it is. And again, thanks so much for the opportunity, Barry.
Listen, thank you so much, Jeff. And listen, you gave a lecture that I can't give. I listen to those lectures every single time, the binding and the this and the tails and the whole bit. So I love the scientific side of it. And quite frankly, that's one of the reasons I wanted to reach out to you, because I knew that you would deliver. And of course, in typical Dr. Barry fashion, I skipped a very important part of the evening. So I'm going to do that now. I'm going to put my Curaleaf hat on and introduce Stephanie Cronin, who is my dear friend from Curaleaf, Florida. And I want to really give a big shout out to Curaleaf as our sponsor for the evening. And I wanted to give her an opportunity to introduce herself and just say a few words about Curaleaf, who is one of the, listen, I don't want to say anything wrong, but I believe is the largest singular medical cannabis multi-state operator in the country. But correct me if I'm wrong. But Steph, thank you so much for being here with us tonight and your support.
Thank you. And yes, you are correct. We are the largest, and I had nothing to do with that. But really, I'm so honored to be here. And of course, all thanks to Dr. Gordon, who called me on a Saturday and said, "Hey, Steph, I have a great idea. What do you think?" And I'm like, let's go for it. So thank you for always being there. You and your wonderful wife, Patty. Love working with you, follow you guys on your trips and everything, and consider you friends besides working together as well. And to all the doctors on here, Dr. Yafai, Dr. Hergenrather, Dr. Knox, Dr. Lassiter, Dr. Price, I know your time is very valuable. We know how busy you are, and we just want to thank you so much for taking the time out of your schedules and be willing to present such amazing information. Because our goal, really more than anything, is education. Education, knowledge is power. Without all of us doing this, nobody's going to know. We still come up against all the stigmas. Even people that work in our company who have family members that don't back them in their choice to go into cannabis. So breaking down these stigmas, educating. Without physicians, this is really nothing. We have a lot of people guessing and trying to understand and figure out what way to go. What does this mean? How does this work? Just as you guys didn't learn the endocannabinoid system in medical school, we don't know, right? I found out educating. I got into this because my cousin, who was addicted to 50 pills because he has a metal rod in his entire back and it will be on disability his entire life, and was suicidal and gained 200 pounds and just could not care whether he lived or died. His whole life turned around because of cannabis. He will always be disabled, but he has a quality of life now that, although to some might be nothing, to him is everything. And I have my cousin back, which is amazing. And that's how I got into this. So just being able to share the story and share the education is an honor and a privilege. And I hope everybody takes something away from this. And we at Curaleaf are always here. I know everyone's in different states and we're all over the country, so feel free. I'll put my email directly in the chat. So if anyone in any specific states wants more information or to hear from a doctor in this state or wherever, please let me know and we're happy to connect. And again, thank you for your time, and I hope everybody sits back, enjoys, and happy 420.
Well, Stephanie, you're getting a lot of love in the chat on Curaleaf products, the new squeeze products that came out today. Everyone is hoping that they can get some larger 8 and 16 ounce sizes going over the next couple of months, but lots of love and great work.
Thank you very much. And that is on our list. And if we can't make them full, we're putting some great packages together that will let you mix and match your 8 and 16 ounces. So you don't have only one strain, but you get multiple strains at a really good price. So thank you, and keep sending whatever input, whatever you'd like to see, let us know. Thank you very much.
And listen, Steph, I brought up like the nano drops
Mhm.
from Curaleaf and things of that nature.
Mhm.
What you have to know is that the cannabis companies are really in the forefront of developing new products for our patients as well. These nano formulations are fascinating in that they're bypassing the first pass liver effect in a lot of ways. So if you really get the products appropriately, so you can bypass a lot of the change to 11-hydroxy and a lot of the breakdown of the CBD products. So kudos to you guys and all the development and the beautiful botanists that you guys have growing all the beautiful plants.
Yeah.
Listen, our second, and thank you so much. And Sophia, thank you for bringing up the chat and keep on doing it. Listen, I had to have Dr. Lynn Lassiter on tonight. I think you're currently still in the hospital right now, right? Would that be correct?
We can't hear you.
Yes, that is correct. I just finished my 12 hours and I'm doing my second job now. So happy to be here. Pleasure to be on with such amazing and honorable pioneers in this industry. So I'm so proud to be learning from all of you tonight.
And thank you once again for doing that 12-hour shift. Okay, so our next presenter, and once again, this is a gentleman who I've also had a chance to meet out at the Emerald Cup. Dr. David Knox. And, you know, David's out there in Oregon with one of the most famous families in medical cannabis, and literally the family that has, you know, I don't know if you guys have trademarked it, but you should. The term endocannabinologist, I believe, came out of your guys' zone, David, and it's such an honor to have you with us tonight. So when I gave Dave the discussion on psychiatric issues, he was funny because he emailed me back. Those are the charts that I always try to avoid in the ER, right? Like every single one of us, because of course there's never, let's put it this way, maybe in the old days when there was a social safety net of follow-up and referral and things like that, maybe the psych patient would get good care. But now we know the nightmare of clearing patients for inpatient admission and waiting for tests that aren't necessary. And quite frankly, sending patients out to an abyss of care right now to the extent of follow-up. So, but I did give you the psychiatric side of things, David. And it's important too, because there's such a discussion these days, and you'll see in the THC cap, the 10% discussions, that they're always talking about a few studies of a, you know, a schizophrenic response or a psychotic response due to the cannabinoids, cause and effect, always being the big bugaboo with these very poorly done research studies. So I'm going to cue it up for you. And once again, thank you so much for joining us. And also another one of us. And how many years did you do in the ER, Dave?
All right. Well, thank you, Barry. Yes, I retired after 40 and a half years at the end of 2018. And I'd say it was pretty good timing. But yeah, I became involved in the cannabis space about 7 years ago when I started seeing patients in the cannabis card clinic. Actually, yeah, you're right. My wife started this. She got into the space before I did, and you know, got me introduced, and also, you know, I'd say up until that point, having been conventionally trained, you know, we really knew little about cannabis medicine. And so since then, this experience has really been eye-opening, and it has rekindled my whole enthusiasm for medicine with a new life in endocannabinology. So yes, my wife and my two daughters, who are also both physicians, were part of the Doctors Knox. You know, we'll take a little credit for inventing that term here, but yeah, the patent you know, specialist, so it wouldn't let us actually patent it, but I think it's a good description of what we're dealing with here. So I started seeing all these patients with many complex medical problems. They were seeking cannabis for their treatment. Remember, you know, end-stage people coming in their wheelchair on oxygen, but they were willing to pay their money to get their cannabis authorization. It's just amazing. Especially seeing the many patients reporting pain relief and reduction of their need for opiates were really some of the most convincing factors for me that medical marijuana really is real medicine. So since then, as I've learned the science behind the whole endocannabinoid system and then the application of cannabinoid therapies is absolutely amazing. But as we know, research still has a long way to go. It's going to take a while. We've lost, several generations of research that should have been done. But I think we're on the right track now. It's going to happen. As Dr. Gordon alluded, I was a good choice to talk about psychiatry. I don't really agree with him. I really don't like psychiatry, and he's right. Every time you saw that psych patient show up on the board, I was kind of scheming, how can I avoid getting assigned? Give me a simple laceration or belly pain even, The other thing I really don't like is statistics. I think the quote about lies, damn lies, and statistics. And I think it's really true in this area. When you delve into the literature about the psychiatric issues in cannabis, it's just nothing but statistics. There are uncertain conclusions that are based on interpretations of meta-analysis of other statistical studies of the reported incidence of psychiatric disorder. I always have to question, if it takes a meta-analysis to show something, is it real? It makes me stir crazy. So bottom line, while there may be a concern of association of psychiatric disease with the use of cannabis, there's really much less evidence of causality. Let me share my slides here, and I'll kind of, just so you don't have to look at my ugly mug here the whole time here. I just have to say that there are so many issues in this area that really can't be put into 15 minutes or less, but I was just going to try to cover a few points just to start the discussion. So this intersection of cannabis and psychiatric disease is a difficult area to reconcile. And most national organizations who are not willing to endorse cannabis as medicine cite these issues as primary concerns for their disapproval. So the concerns about creating more psychiatric disease engenders a lot of debate about the wisdom of moving to legalize cannabis at all, whether medically or especially for recreational use. Nonetheless, there's an essentially patient-driven push for the use of cannabis for many psychiatric reasons due to the perceived benefits of cannabis for their symptoms. Patient states are using cannabis especially for anxiety and post-traumatic stress disorder, but also depression and even bipolar disorders. Their help with sleep is also frequently cited, as sleep disruption is a common component of all these disorders. Now, PTSD is almost universally listed as a qualifying condition for medical cannabis authorization in the states with legal medical programs. Anxiety is considered to be the most common mental illness, impacting 40 million patients, or about 18% of the US population. And 50% of people with depression also have anxiety.
Hey, Dave,
So while general anxiety may not be a qualifying condition, many patients who have other qualifying conditions like chronic pain often report that they use cannabis as much for its anxiolytic effect.
Hey, Dave, we're not seeing your slides, so it must be a screen share thing or something. So
Are you not seeing my slides?
We are not. So hang on, Don Tech Guy.
Yeah, well, let me
okay.
Let me try one more time here.
That's all good.
You got it yesterday.
Yeah. I said I have no worries about anybody's presentation. It's always the tech stuff that, there we go. You got him. Okay.
Okay. Is it there now?
Got it.
All right. So I just wanted to do a quick review of the physiology of the endocannabinoid system in PTSD and anxiety. I think as Dr. Hertenrother alluded to, PTSD is considered to be an endocannabinoid system deficiency disorder. And in the studies, they show that reduced levels of peripherally measured anandamide and abnormal CB1 receptor signaling and a compensatory increase in CB1 receptor availability are implicated in not only the etiology of PTSD, but the degree of intrusive symptoms. So a low ECS tone contributes to hyperactivation in the amygdala, and this causes anxiety, and the hyperarousal symptoms of PTSD including sleep disturbances, memory, and cognitive impairments, as well as depression and suicidality. So CB1 receptors in the brain limbic structures are involved in modulating behaviors, mood, stress, learning, and memory. Studies have shown that activating CB1 receptors in the amygdala can potentially block the consolidation of aversive memories, fear, and anxiety. CB1 receptor activation in the prefrontal cortex may increase serotonin with the resultant antidepressant effect, and activation of the receptors in the hippocampus seems to improve neurogenesis, mood, and memory, while decreasing hypervigilance, hyperarousal, and other intrusive memories. So as Dr. Hergenrather also illustrated beautifully, THC mimics anandamide. You know, it's a moderate agonist at the CB1 receptor, but then studies are showing that it's biphasic in nature. Low doses do seem to work very well in reducing anxiety, but as we'll see, high doses can increase anxiety. Now, CBD acts quite differently, as it is not an agonist at the cannabinoid receptors, but it still has been shown to be anxiolytic in a lot of studies. It does bind allosterically to the CB1 receptor, reducing the affinity for THC, and notably, it has been shown to reduce the anxiety that THC can induce. CBD really acts directly more as an agonist at the serotonin 5-HT1A receptor, and action is somewhat similar to the FDA-approved drug buspirone. Also, CBD inhibits FAAH, which is fatty acid amide hydrolase. That's the enzyme that breaks down anandamide. So as a result, it increases anandamide levels, which then work on those cannabinoid receptors for their effect. So it's notable that CBD also has a bell-shaped response curve, notably because it activates a lot of different receptors. The number I've heard is that there are 65 different receptors that CBD is involved with. And here, a high CBD level may activate the TRPV1 receptors in the periaqueductal gray area, and that may override its otherwise anxiolytic effect in those high doses. So we really kind of see why cannabinoids should work in treating these conditions here. They've done surveys showing that more than 50% of PTSD patients report good relief with cannabis. They have improved sleep, decreased nightmares, improved functioning. They really have a feeling of improvement in their overall well-being. And there are many other studies that show that cannabinoids can reduce anxiety. There's also a recent study that was published that showed over the course of the year, patients who are using cannabis, and admittedly along with their other therapies, were 2.57 times more likely to no longer meet those DSM-5 criteria for PTSD. However, we do have to admit the literature and the data to support this cannabis use is really limited. There's often mixed results in these studies. They may range from there's no correlation, or there's no difference from placebo, or they show there may be increased risk of association of cannabis use with anxiety. They suggest there may be a disconnect between the acute benefits of anxiolysis and sleep and a longer-term potential for worsening anxiety and depression. Now, the literature for bipolar disorder is even more limited, ranging from short-term improvement to an association with longer affective episodes, more frequent mood cycles, and longer or lower remission rates. Or some show just no relationship at all. So we think that there may be a methodological shortcoming that underlies this discrepancy between patients' self-reported benefits and their scientific evidence. You know, a lot of these studies are limited in controlling all these variables of the how it's administered, what dose. We've noted the influence of biphasic effects. And a lot of these are retrospective studies with really unknown doses that were being involved. So if there really is this lack of scientific evidence, one answer to the question why patients still are having such a demand for the use of cannabis, it may be revealed in a recent survey that was done where they compared cannabis with other pharmaceuticals, most of which are the antidepressant class of medications. So these respondents noted that cannabis was most likely to improve their PTSD symptoms and least likely to make them worse. So in comparison, 18% of them reported improvement on standard antidepressants, where 50% actually felt they were worsened on standard antidepressant pharmaceuticals. I do want to note here that 50% of the patients in that study reported they were using CBD-rich cannabis. So we're really talking about issues in the emergency room here. So I want to address a few issues of concern there. Acute toxicity from cannabis is singularly THC related. Acute toxicity with a high dose can cause numerous side effects, beginning with the physiologic response of just increased heart rate, dry mouth, dizziness, headaches, and acute nausea and vomiting may occur. And overdoses often result in dysphoria, not euphoria, but you get increased anxiety, which can escalate to the point of panic and even paranoia. And these are the patients that come in the ER stating, I feel like I'm about to die. Now, rarely overdosing may produce an acute psychotic state, and a toxic delirium state has been described with altered orientation and even consciousness. But acute psychosis in most of these cases is generally transient and resolves as the THC intoxication wanes. But sometimes symptoms may last, days or longer. This may be a little different than cannabis-induced psychosis, which can develop gradually and persist. And again, is associated with long-term exposure to high THC cannabis. And it may be somewhat hard to differentiate initially from other causes of psychosis. There's also another lesser known and rare side effect that I just recently became aware of, what they call a depersonalization, derealization disorder, where patients really feel separated from themselves and can affect their perceptions and functioning. And this is symptoms that may persist for weeks, months, or it's even been described as lasting for years. So it was an interesting thing to learn. Anyway, most of this toxicity seems to be dose dependent. And so that raises the question, there may be an increased risk with the use of concentrates. Dabbing, for example, results in very rapid intoxication with very high serum levels of THC. The rapid onset, though, is also generally limits their continued use, although I have seen a few patients in the ER who were just really kept dabbing so they could see how much they could really do. He presented with a nice acute chest pain. But as I think Barry mentioned here, toxicity is most common with edible products. The reason being is that they're very slow in onset. People get impatient and they waiting for something to happen. They say, I'll have a little more. And it really leads to overconsumption. The intestinal absorption route also is complicated by that first pass metabolism, as Barry alluded to. The first metabolite of the cytochrome P450 enzymes in the liver, delta 9 is converted to 11-hydroxy-THC. I always say 11-hydroxy-THC is active and at least 5 times more intoxicating. And then your serum levels of 11-hydroxy-THC may be 5 times higher. So that's what results in that long, strange trip, 5 times 5, may last even 12 hours. So how do we treat these in the emergency room? Well, most patients really don't need much treatment other than reassurance, a calm environment. They're able to be talked down. And then the sedative effects of cannabis often set in and kind of self-regulates those type of reactions. Sedative medications are rarely needed, but you can give small doses of benzodiazepines. And in general, I think treatment with antipsychotics is also not necessary, even if they have active psychotic symptoms evident at presentation. This is still generally transient in most patients. For that real cannabis-induced psychosis, however, antipsychotics may be needed. And it was interesting, we often use olanzapine or haloperidol, and they may be effective, but there are also reports that it may worsen symptoms or just not help in some patients. And as an addition, carbamazepine may also be helpful in helping control those symptoms. So, of course, this discussion of toxicity leads to the next question. Does cannabis cause schizophrenia? How at risk are we of seeing a lot of increased, more severe psychiatric outcomes following this legalization of cannabis? And I tell you, this area is another big statistical rabbit hole. What we do see that some studies show an increased incidence of diagnosed schizophrenia in a dose-dependent manner with a degree of cannabis use, but still without a strong level of evidence to support causation. Some studies showed that among patients seen in an emergency room with an acute psychotic episode may have 5 to 6 times a higher risk of being diagnosed with schizophrenia at some later time. Another study showed that 50% of patients with cannabis-related psychosis will go on to develop schizophrenia. So this has led some authors to say that any patient seen for cannabis-induced psychosis should be admitted or at least referred for close follow-up for further psychiatric evaluation. There also have been some genetic studies that have identified that higher risk of subpopulation with certain markers. So I was very interested to hear about, those variations in the CB1 receptors themselves that might be part of that contributing genetics here. As part of that, there's also concern that patients who might have a genetic predisposition to schizophrenia would seem to start showing symptoms of schizophrenia at a younger age if they used cannabis. So that led me to kind of look at what I could find for statistics for increased emergency room visits for cannabis-related problems. And another interesting number of statistics here. They've done statistics based on coding, which always raises in my mind a question, well, is it a change in your coding practices or is it a real change of incidence? But I'm sure there's some studies who have looked at that variable as well. But here's your 2014 case study in Colorado. Cases coded with cannabis were 1.6% of visits compared to 0.78% before legalization. That's a nice double. One hospital reported triple the number of cases. And as an aside, it was notable that there was a 109% increase in ER visits by tourists in that same time period, suggesting that their naivety to cannabis might have contributed to that. Another similar study showed that cannabis was involved in 0.8% of ER visits, but that was increasing 7% a year. Of these cannabis-related ER visits, a consistent statistic is that about 25 to 30% were psychiatric in nature, as opposed to hyperemesis or other concerns. They also showed that there was 5 times the prevalence of mental health codes associated with cannabis codes. So you have to admit there is a high correlation of cannabis use and mental health disorders. Again, we have a hard time saying about causation again. These numbers do seem somewhat worrisome, but why is cannabis still considered to be relatively low risk indulgence by a majority of people? Well, here's the overall incidence of psychiatric disorders is approximately 1% at any time. And it really has not changed much at all over decades. Then you look at the lifetime prevalence of all psychotic disorders, which they estimate to be at about 3%. That is the percentage of us who will have a psychotic episode of some type during our entire life. And these can be broken down by categories, as you see here on this slide. And of these, the substance-induced psychotic disorder was only 0.42%. And that included many other substances as well as cannabis. So while there is evidence that cannabis may be a risk factor, yeah, I got ahead of myself. It's still really not a very high percentage of us that are developing that side effect. So we always say if you have less than a 1% chance of becoming psychotic and you take on an activity that might increase your risk by 100%, well, you're still really only at less than 2% risk. So that likely won't change anybody's personal assessment of what risk they are taking. I always saw this other study that showed a statistical extrapolation. They estimated there might be 200,000 additional psychotic episodes with the use of cannabis. But when you divide that by 22 million users in this country, it's still less than a 1% risk. You know, any one of them are not that likely to have that experience. But one fun fact I always like to cite about statistics is that they're just a bunch of contrived numbers unless you are the statistic, and then it's 100%. So obviously, I'm in the business of using cannabis as medicine. So you might ask, how do I reconcile this use of cannabis against the risks of unwanted side effects, poor efficacy, or toxicity? Well, first, over the decades, cannabis has been studied, and the conclusion has been that it has no more overall risk than any other pharmaceutical product in use. And these were government studies that said that. Like all medicines, there's a range of appropriate use, misuse, and abuse. But unfortunately, cannabis carries that stigma of being used historically for the purpose of intoxication. So while cannabis cannot be considered to carry no risk, the risks that are known can be weighed against the benefits of use for any medical problem. So most of these studies in psychiatry have been observational and reflect recreational cannabis, which is known to have higher THC potency and low CBD concentrations. There are very few studies looking just at medical users who generally are not seeking intoxication. That's the other thing that astounded me from the get-go. How many patients come in saying, I don't want to get high, I just want relief. So as we have noted here, the association of cannabis with psychiatric disorders is mostly THC driven. And I believe that medical users are somewhat different than recreational users, and that educated patient, and we can also argue that educated consumers, can limit many of the risks of cannabis. For example, as we noted, patients getting good relief of PTSD symptoms were using that CBD-rich cannabis. Then they also are having more recent trials, really looking at using CBD itself in the treatment of psychotic disorders. So we just have to say that there's still no absolute contraindication for the use of cannabis in some form. And finally, on an individual level, we can screen our patients for risk factors, that family history, prior adverse reactions, psychotic events, and we can caution those patients against the use of higher THC products. We know CBD is the biggest moderator of THC intoxication. So if you have a good balance of CBD with THC, you have much more control over your adverse side effects. Well, we say our mantra is that intoxication or getting stoned is not necessary to achieve medical benefits, whether for pain, PTSD, anxiety, or anything else. We always recommended that other mantra, start low, go slow. You start with a low dose, a high CBD to THC profile. You slowly titrate your dose and ratio so that you find that minimal effective dose, hopefully without experiencing any of those adverse side effects. Total daily doses of THC rarely need to exceed 20 to 30 milligrams for most medical conditions, and that keeps that THC per dose essentially below that intoxication threshold. Then we also are learning more and more about the minor cannabinoids, and CBG is really coming on. CBG and CBGA, that's cannabigerol, kind of the mother cannabinoid. And then the acid molecules, THCA and CBDA, they're all showing great medical benefits without the risk of intoxication. So in conclusion, while cannabis is not risk-free, I think from a medical standpoint, there are many ways to limit the risks and achieve optimal benefits for our patients with the guided use of cannabis. So just to show, I was able to list 21 references there. That's just a smidgen of the thousands you can find if you go to PubMed. There's lots of information.
Fantastic, David. Thank you so much. Once again, a presentation that I can't do. So no, I mean, fantastic, very comprehensive and very much appreciated. And it does raise the issues. You know what? One of the big things about the studies on PTSD per Sue Sisley is that she can't get good product to use, right, for her study.
Absolutely.
So she's forced to use the garbage from University of Mississippi, and it's really impeded, what we know is the research that needs to be had. And I see a very active chat going on. There's great.
Yeah, you got a lot of great questions, Dr. Knox.
Fantastic. Listen, I saw Peter Grinspoon was with us, and I know he had to leave, but that's Lester's son. Dr. Mike McKenzie, Kelly King, I see out there, Josephine. Welcome to everybody tonight. Fantastic. Any specific, Sophia, if there's any specific questions, why don't we save them and batch them? Because
of course.
Sure, because I see the chat going back and forth, and I love the interplay. But I have to get Dr. Yafai on because I'm just itching to tell the story. So this, everybody, is the ad in Emergency Medicine News. Okay. So Dr. Yafai writes the column, A Case for Cannabis in Emergency Medicine News, which I've been receiving forever. It's the largest white journal in emergency medicine. So she's the one member of the panel that I actually have never met because it's post-COVID. But I became very interested in Sherry's Sherry's column. And in fact, that's where Dave Knox comes in, because there was a very bad article in Emergency Medicine News that a lot of us Canadocs got really outraged about. And Dave literally wrote about a 6-page rebuttal to it, and we got very inspired. But I said to Sherry, listen, ER doctors make the best medical cannabis doctors. We just do. And I'm going all the way that way. And there's reasons for that. But Sherry then got the idea to write a column. We discussed it about medical cannabis doctors who used to be ER doctors, right? And Dr. Lynn Lassiter is there, Dr. Rich Temple, and Bonnie Goldstein is the third, and I'm the fourth. Such an honor. So I had an idea. I said to Sherry, let's do an event tied to the article. So the article's supposed to be right here. So because they didn't do it, I'm not going to get mad at Emergency Medicine News and have them come after you, Sherry. But the point is, they messed us up. But I'm still very, very proud of everything that you do for medical cannabis community, taking the message out to the readers of Emergency Medicine News, still practicing emergency medicine, of course. And of course, having your cannabis practice in LA, queuing it up for dear friend who I can't wait to meet post-COVID, Dr. Sherry Yafai.
Thank you. Thanks so much for creating, coming up with, hosting, doing all the legwork for this great afternoon discussion. And it's such a valuable thing. And I think it's so important to get, not just like-minded people together, but people who have questions, because I know I was there just fairly recently myself. And unlike Dr. Hergenrather and Dr. Knox, who's probably been a little bit more my senior here with these, it's been such an important part to get the word out to other ER doctors who are still in the thick of it, who are still trying to figure this out, who are still scratching their heads, to medical students who have no clue what's going on. That's where I was 2 decades ago. God, I can't believe I said that out loud. Where we didn't know what the ECS system was. We didn't know what cannabis really was. I mean, people would throw out the word medical marijuana and I'd laugh at them. I'd be like, that's a bunch of hooey balooey if I ever met anything about it. And the people who would show up to the ER, I work out of Los Angeles where it was medical for over 20 plus years, but it was always on the like quiet aspect of things. It was never a thing where everybody wanted to really be a part of it. We would talk about it in the ER as if we were talking about, something really scandalous, right? And one of the things I really wanted to bring to the emergency medicine news column was this idea that everything has a negative and everything has a positive. And we cannot, as physicians, draw the line on just the negative. And we cannot spend every single news article that we write about just cannabis hyperemesis syndrome. Like it's one aspect of all of it. It would be akin to having every single opiate article be about opiate overdose and death. And gosh, like we know that, right? We know that, we're aware of that, we're being cognizant of that. How would we feel if every time we talked about opiates, we talked about the rate of the rate of death, the rate of overdose, and the opioid epidemic? I don't think that would be a very even keel conversation, and nor would anybody, quite frankly, like it. We all recognize that opiates have a place and a value, but we all recognize its limitations. And that's really where we need to be with cannabis. We need to recognize its place, its values, and its limitations. And listen, there's nobody better in my mind to have those discussions than ER docs, because we see the good, the bad, and the ugly in the ER, and we deal with it all the time. And the one thing I don't see all the time, I think, Barry, you mentioned this like right from the get-go, is alcohol. We see it in the ER over and over and over again. We see it in our homeless, we see it in our wealthy, we see it in our middle of the road people, we see it in our youth, we see it in our old, we see it in our average age patient. We see it everywhere. And the problem with that is that we don't talk about it enough. So, we talk about opiates a lot now, we talk about cannabis, in our worlds a lot, but we don't talk about the trials and tribulations of alcohol and the social setting that is every time you pick up a TV show, a movie, a ad or commercial on TV, if they're adulting, right, they have a glass of wine in hand or they have beer in hand. I was watching my child's shows the other day and the kids were kicking around with like a bottle of like cola or soda or something that looked like they were having beers. I kid you not. And I wanted to write to the TV show and say, what are you doing from the tender age of like 5 to 10 to introduce a bottle of a beverage, right, presumably alcohol looking, into the idea that this is how people kick back and relax as in elementary school, right? So these ideas and concepts we have to be really firm about, and not just firm about its benefits, but also its potential detriments. I'm going to say one more thing on my soapbox here, and that's that we also need to understand that on the internet, which is the whole digital age of 2020, thank you so much, COVID, you have now given the internet so much more power than ever before. The internet is filled with people who are big advocates for cannabis, which is wonderful because that's how we all got here. But it's also filled with people who are profiting off of cannabis, and we need to be mindful about what they're allowed to say, how much is good enough, who they're talking to. Otherwise, we're going to get ourselves into a position where nicotine was being advertised to children. It was being advertised as the best thing, since white bread. And it is not going to be that way for cannabis if I have anything to do with it. And we need to be mindful that if you have a condition or a situation, or if you want to relax, I have no issue with cannabis being used, clearly, but I do have an issue with people picking up a vape pen of cannabis and smoking THC from the time they wake up in the morning to the time they go to sleep at night, because they're bored, they're sitting on the web, they're watching TV, they think it's good for them, they think that that is healthy. That's not the right perspective we want to bring to all of this. And the problem is none of us here are bringing that perspective, but none of us here are also kind of in a position to correct that perspective until we all get on the same page with all of this. So it's really important that we have these types of discussions and that we all come together and meet and talk about it, you know, very frank and very, you know, very real is what I want to be, right? And so, so going back to Dr. Barry Gordon and my thank yous and my so appreciations here, I think this is such a wonderful event. I think that the more we can get columns like the case for cannabis into printed papers that all emergency physicians read, that other physicians are available to have access to, is so valuable. That's how I met Dr. Lynn Lassiter. Dr. Knox needs no introduction, as neither does Dr. Hergenrather, as you guys have been just so amazing in all of this. Dr. Ira Price has been a pleasure to meet while we get all of these things going, and we're going to keep getting this moving forward. So I wanted to I'm going to bring up a couple of the chat questions too as I share my screen and get everything moving and shaking. All right, so I wanted to talk specifically about, can you see the cannabis part of the screen here?
Yep.
Okay, perfect. So I want to talk about cannabis in Los Angeles, or here in California, I should even say, and how that's changed, especially as we see more and more legalization going through in other states. I had the pleasure of talking with the marijuana menches recently, thank you to Dr. Gordon, where we're seeing New York legalize, and how this is going to change our practice as physicians, right? Because that's an important aspect of things. And I started my practice in cannabis right as legalization recreationally happened in California, despite the fact that 75% of other cannabis offices were shutting their doors down. And what did that all look like? So it's really important that we get these kind of concepts and discussion points going together as we move forward. So just a quick brief shtick about me. I went to UCLA for my Bachelor of Neuroscience, went to UC San Diego for my both medical school and residency in emergency medicine, and then started here at a local community hospital at Providence St. John's in the ER. COVID has, you know, changed that practice even, and thank you to COVID, I have dropped down in even further so in number of shifts, but it's really helped my pivot. And I call it a pivot because I didn't retire. Unlike some of the other docs here, I didn't retire into cannabis. I really took this as a, you know, I oftentimes liken it to the old school cars where you would push the gas and let go of the brakes slowly at the same time. And that's really the way I leveraged into cannabis medicine. I didn't jump in at all. I had cold feet. I don't like doing that kind of stuff. So here in 2016, I really pivoted into cannabis medicine. And at the same time, I got angry because I have a bit of a pit bull personality, in the words of one of the trauma surgeons who worked with me. He called me the pink pit bull, and that name has kind of stuck because I tend to get frustrated and push forward. And so I pushed with John Wayne Cancer Institute to demand that we needed somebody to start teaching in the world of cannabis that was reputable and had a relationship with our physicians, because you can't come in cold to other docs, right? You can't have a pharmaceutical rep selling pot to doctors. You can't do it. It won't work. Nobody's going to trust you. No one's going to believe you. And we're all going to poo that as to, like, that's just not working out for anybody in the hospital. But what we need to do is push forward with the medicine, and we need to push forward. And I came under the wings of Dr. Hergenrather. Jeff kind of took me in on the SCC, and that's where I learned so much more about cannabis as medicine. And anybody who's interested in learning about science, clinical medicine, you know, every time I listen to one of the journal clubs, even now on the monthly basis that it's going on, I learn something new. And more importantly, when the doctor down the street who's a cardiologist hears peripherally through doximity.com that cannabis and THC is bad for the blood pressure and bad for, you know, cardiac medications, I'm now able to have a much more intelligent conversation with them because I read the article. I didn't read the article. I listened to somebody else who read the article in much more depth than I did. And that's really important in medicine, right? We value those discussions and those conversations. And I would really urge everyone to join us there. So that's where I will leave off on that boring educational background. And I wanted to jump in. We've already done, Dr. Knox did a great job about cannabis emergencies. I want to touch on just 2 points that came up in the chats as you were going through all this. You know, how frequent are cannabis emergencies in the ER, right? Like how often do we actually see that? In our small community hospital in Los Angeles, we don't see it very often. At UC San Diego, at four major emergency departments there, we didn't see it very often, but that was also pre-legalization. Legalization has changed that quite a bit. We do see people show up from, you know, the last 3 patients I saw with cannabis emergencies in the ER. One was a 20-something-year-old girl who was here from out of town, and now that she was in a legal recreational state, took a gummy, didn't feel anything, so 20 minutes later decided to take a second gummy, and boom, right? And scene, right? Everybody knows exactly that story. I've had oodles of housekeepers who took their, you know, their proprietors, I don't know what the right word is, their homeowners cannabis products by accident. It was chocolate, it was in a brownie, it was delicious. It is always delicious. Kudos to the cannabis industry for making a medicine that is delicious. But they don't know that it's in there. And so they take a little bit, it's delicious, and they take more. And so one of the really important regulatory pathways that California, I'm very proud of, has taken is that you have to have it labeled and you have to have it pediatric proof, or you have to have a safety basically break on it so that people don't just open it up like they think a bar of chocolate, like of a Hershey's bar. So that's a really important factor that's helped mitigate a little bit more in terms of pediatric emergencies, especially here in California. And it's something that we learned from Colorado, because we did see an uptick in Colorado's pediatric emergencies. And Dr. Knox talking about statistics, it was like a whopping 200% increase, but it was really, I think, something ridiculous like 4 to 8 or something like, you know, the emergencies were not that many, but when you talk about percentages, it really creates more of a wow number for people. So that's really important. The other more common emergencies I'm seeing nowadays in the emergency department in Los Angeles is geriatric patients. My grandkid now gave me a piece of chocolate and they said it would make me feel better, and now I'm vomiting and having a panic attack. So again, it's really important because the education factor of our, you know, teens, 20-something, 30-year-olds, 40-year-olds who have grandparents now that they think this is useful for, you know, appropriately, they don't know how to dose it for their grandparents. They don't know how to administer it to their grandparents, and they don't recognize that what is my dose as a daily cannabis user should not be the same as the one I'm giving to my grandparent who's never used this stuff before. And that's really where this education and the value of physicians needs to come into play. I think, Barry, you mentioned this really nicely, is safety and education, right? We have to be able to provide this really nicely for our patients. Now, the other thing is it accidental? Is it on purpose, right? This is one of those things that differentiates an overdose in the ER is something that we are going to keep you in the hospital for 5150, or are we going to let you go home after you feel better? And almost always this is accidental. I have yet to see an intentional cannabis overdose in an attempt for self-harm. It never happens. And I would beg anybody to tell me otherwise, because that's really something that I have never seen, never heard of, never heard a case report of, or anything otherwise. So it's really important to know that nobody's using this because they want to kill themselves, right? We overdose on aspirin, we overdose on Tylenol, we overdose purposely on all of those things that are not just legal, but over-the-counter use. So that's another important side kind of discussion with that. We do see pediatric, adult, and geriatric overdoses. It happens in all ages and all extremes. But there are also 2 different types of overdose that we see in the ER. So one is nausea, vomiting, tachycardia, panic. I feel miserable and I feel like I'm going to die. And if you don't have a story about that, I dare you to ask one of your friends, and one of them is bound to have that story. And if you don't have a friend that has that story, you're probably not an ER doctor, because most of us have friends who live on the edge, right? So it's an important attribute of an ER doc. Now, the other extreme, and with those, sorry, one more second, with nausea, vomiting, tachycardia, and I feel like I'm going to die, that's something you can give Ativan or benzodiazepine to, and it will go away or dissipate. They'll fall asleep and you'll send them home. It doesn't tend to expand beyond that. Now, there is another type of extreme overdose reaction, which is bradycardia and sedation. And I've only seen that happen really twice. And that's happened in my small pediatric patients, and not my personal patients, actually. These are case report cases of 5-year-olds or 6-year-olds who accidentally took cannabis products, presumably THC, that was lying around, unclear dosages, but for a 5-year-old, any adult dose is probably going to be too much. And in both those cases, what happened was a cardiac pause, and both of them resolved prior to any intervention in the ER. So it leads us to believe that this is not healthy. No one's saying this is healthy or desirable, but what it is saying is it's not lethal and it's going to pass. And that's important as well. Just as important as knowing how to mitigate a negative response is how to not intervene and go to paddles and do cardiac, CPR on a 5-year-old when it's not necessary. So also important factors. So the last chronic emergency I wanted to bring up, and this was being discussed in the chat right now, is CHS, or chronic cannabis hyperemesis syndrome, or vomiting. Okay, so this is something that's really important because we're seeing it more and more. It's a reality that I hate to admit it, but it's a reality with more states that legalize. But I think the problem here is, and I did a bit of a rant on my last emergency medicine news column about this, is that the problem is not the acuity, right? So this is something that's typically ongoing and people are overusing on an ongoing basis. And the question becomes, how do you treat it? Do you treat it with Haldol or Droperidol or a Zofran or another antiemetic? Or, and this is where I really want to get more comments here from everybody else. And Sophia, if you could do me the honor of looking at the chat, if you think that it would be more beneficial in the long term, right? ER is all about the short term. Do you think it would be more beneficial if we actually did more education about, hey, what are you using? Because most of my ER colleagues say, oh, you smoke pot and you're vomiting? All right, I've got the answer now. The answer now is CHS. But maybe that's not the answer, because if they're smoking twice a day, the likelihood that they have CHS from chronic cannabis use is probably not there. That's probably not the etiology of what's going on. So could we educate patients? Like, do you think that would be just as viable a treatment plan? Like, you are using, you're going through 1 gram a day inhalation, plus you're using 4 chocolate bars a day. Maybe that's what's going on in terms of your cannabis hyperemesis syndrome. Maybe we need to cut out the chocolate bars because you're smoking enough that the chocolate bars are doing absolutely nothing for you, or the edibles of choice are doing absolutely nothing for you, just smoke. I mean, that's really the question, right?
For sure, Sherry. And that's why I gave him an entire section on cannabis hyperemesis syndrome, because he is the Canadian expert on it. So,
so I guess I will defer, but I want everybody to just kind of start ruminating about it. Where is it that this is going to be a discussion, not just about treatment? It's always like, give them more medicine, give them more medicine, give them more medicine. Maybe we need to give them more education. If a diabetic showed up into the ER and was, hyperglycemic, and we give them the right medication, fluids, insulin, etc., and you get their blood sugars down, don't you educate them? Aren't we mandated to give them education about how to use their insulin better? The question becomes, why aren't we teaching people how to use their cannabis better? Shouldn't we be mandated to teach them how to better use this stuff? It's not just treatment in the moment. And that's something that really kind of is very valuable to me, is let's get past this. So I was also tasked to do a quick discussion about population over 65. And if you can appreciate that photo, I wanted people to actually take a step back and say, it's not just numbers. I get back pain too. I'm not 65 and up. It is terrifying to me sometimes, but it happens. And we need to really address the fact that everything is not geriatric. It can also be normal age population where we get back pain and, and other areas of pain. So I stuck my face on that because I had a geriatrician talk about how maybe we are mislabeling the way geriatrics look these days. So as to not offend the geriatric population, I wanted people to see a different kind of face on there. But population over 65, dementia, Parkinson's, earlier I think Jeff mentioned neurodegenerative diseases in general and other areas of pain. It's so important. We are just starting to see the tip of this, where CBD and THC can be potentially beneficial in, dare I say it, the prevention of dementia and the prevention of Alzheimer's dementia. Maybe it's a little bit more of the cleanup crew for the, the deposits that are set down in the brain than we give this credit for. And we're starting to see not just lab rats out of Germany with improvement in cognition and prevention of Alzheimer's in those rat models, but we're starting to see it in our human patients. So I had a patient just the other day who's in her 70s, and her husband and I do a lot of the discussion, and we were talking about how within 3 months of cannabis treatment, she is showing improvement in cognition. And this is after him spending over 3 to 5 years worth of cost, money, time, effort on ultrasound technology on the brain, MRIs, fMRIs, nonsense MRIs, doing stem cell therapy, doing injection treatments, doing just all sorts of huge financial cost to them, and time and energy. And also, we don't even talk about the anxiety that's there in the whole ripple effect of family members. Is grandma going to remember me today? Is today going to be a good day for grandma? Is she going to be violent? Is, grandpa going to be abusive today? Is dad going to be hurting me today? Is he going to remember who he's talking to today? And that whole ripple effect that's not benefited from our typical pharmaceuticals. And you listen to any Alzheimer's talk, even today, and they will tell you that we have poor treatment right now. We don't have good treatment. The best mode of prevention that I've heard to date, and I listen to a lot of these talks, is exercise and do Sudoku puzzles at the same time. And I don't know about you, but I can barely do that. I multitasking in that frame of mind and reference is a big challenge. And it's a big money maker for those people who can do that and can provide those. They're called neurocognitive physical therapy clinics. But it's really important to be able to provide these very simple, low-hanging fruit that's a low cost and easy access to all patients. And that's going to find a lot more improvement. So these are just really basic things. Now I picked, because pain can be a whole conversation in and of itself. In fact, for the SEC, I just did a 1-hour clinical module on pain management. And if you're really interested in how to manage pain with cannabis, please feel free to go to the SEC website, cannabisclinicians.org again, to get that clinical module. I think it's like $39. I mean, it's totally worth it, in my opinion. I don't get any of the profits from that, just so you all know. In that 1-hour module, I also want to tell you, I talk about how to reduce opiates with the use of cannabis. That sits near and dear to my heart, just as much as geriatric medicine does. It is so vital, not just with opiates, but with alcohol as well. And I hear time and time again, patients say the exact same thing to me, and they've never heard each other talk. And I never say this in front of patients. They say, it just makes me not want to pick up that second drink. I don't really want it. Word for word, every time. It's not that I don't want to get high, I don't want to get stoned, I don't want to, I'm trying purposely to stay away from it. I just don't want it. It doesn't make me feel good anymore. So going back to arthritic pain, because I think this is one that can be used far and wide for so many individuals across the country and across, I think, every continent. Everyone's got some level of arthritis. This is my favorite study on rat models, where it was topical CBD. I mean, can you imagine topical CBD being a potential huge curative treatment for people, where they don't have to worry about getting high, they don't have to worry about smoking something, they don't have to worry about ingesting something, they don't have to have fear. And that's a really big important thing for a lot of my geriatric patients, is fear of use. And so this is a very easy first step into cannabis, is using the non-intoxicating CBD on top of a joint where it can be really focused and directed treatment. And what Dr. Hamill et al. Showed in the European Journal of Pain was that using topical CBD, and I'll show you in just a second, there's 2 different dosages that she used, can significantly reduce joint swelling, limb posture scores as a rate of pain, immune cell infiltration, and thickening of the synovial membrane. So this goes far beyond just pain management, right? This is not just pain, it's also healing, decreased inflammation. I mean, all of these things that people are constantly asking about. And this is showing it in a very clear model. So here you can see, C is like the picture of C is the normal looking rat joint. Picture D is the arthritic rat joint, and picture E is the picture of arthritic model rat plus CBD, and you get that good improvement in inflammation and swelling, okay? It's really important that you see those big differences here. The other thing that you're gonna look at is, sorry, I got cut off here, but the knee joint swelling decreased, the pain scales also decreased. And this was using, the first one was 6.2 milligrams of CBD, and the second dose, the more potent dose, was 62.3 milligrams of CBD, again in a topical ointment. Now, the one difficulty with this study is that rats, I learned later on, absorb through their skin much better than humans do. So we have to take it with a grain of salt. But I do see the same thing get reflected in patients time and time again. I had one great patient who was 6 months post-op from a knee replacement, who had so much swelling in her knee that the orthopedist gave up hope, her primary care doctor gave up hope. And what ended up happening was that she got referred to me because she still couldn't fit her pants over her knee. She was a professor at a university and couldn't be intoxicated all day, so couldn't smoke pot all day. So we used a topical plus oil tincture ingested, and not only did her knee swelling decrease, she was able to get back into pants, she was able to get back to hiking, and she was able to come off of gabapentin, which I think is a big throwaway drug that we're using way too much of these days. My personal opinion, but we'll just throw that up at you. And it was just remarkable. And these are those types of remarkable things. We're not going to see it in 100% of patients. I like to remind people that a really good medication like GABA has 45% efficacy over a 6-week time period for neuropathic pain. That is garbage to me, 45% in 6 weeks. So when we talk about cannabis and cannabinoids, we're talking about closer to, I would guess, I don't think I've seen any studies on this, but in my patient population, we're seeing roughly about 60 to 75% effectivity for specifically arthritis, I should say. And we're seeing it within days, right? You're not seeing a 6-week lag in this. If it works for you, it works quickly. If it doesn't work, I tell people to toss it and use it on their back pain. So it's important to kind of take these things into consideration. I'm going to throw out one more.
Topicals are crazy, Sherry. In the elderly population, it's just an incredible thing. I never talked about them before they came out, and I didn't talk about them until the patients started to tell me the positives from the topicals. So that's a fantastic study. That's all. Just had to chime in. I mean, the topicals should never be ignored, and patches, topicals, creams, for sure. Yep.
Right. And then I bet you could confirm if this is true, but when I first started practicing and I met a bunch of Canadians, they told me that topicals are illegal in Canada. And I was like, my jaw dropped. I was like, what do you mean? Like, what could be more simple than a topical?
Yeah, topicals.
I'm glad you're queuing it up for Ira,
Okay.
Sherry, because typically, as you know, we're going to run, through time. So I don't want to get the hook to you, but I guess that's my bad job at certain times. So I want to make sure that Ira does get a chance to do his thing, because as you know, cannabis hyperemesis syndrome is that one thing that all ER doctors think they're seeing, and we know they're not. So,
right. So we'll hand off to Ira here, but Ira, I'm gonna segue to you based off of what is legal when we think, oh, everything is legal in Canada, but it's really kind of a misnomer. Is that right? You went to your other job as a DJ? What's going on here?
It's snowing today. And
So listen,
and-
so Ira Price is Canada's best ER doctor. He's their first, he's their best. It's such an honor to have him.
I rep really well.
He's published and written on cannabis hyperemesis syndrome. And once again, Sherry, not to knock you off, but go ahead and segue into Ira appropriately, because I want to make sure he gets a chance to educate all of our ER compadres out there about really what's going on with cannabis hyperemesis syndrome.
Hey, everybody. Listen, you talk about the ADHD doctor. I don't think any of you really understand what it means to be ADHD until you're me. Like if you can only see what this table now looks like from the last hour and a half of listening, I've got look, I even went to find my daughter's toys. I've been playing with this thing. Like I've got stuff lying all around here now because I'm eating nuts. I got coffee. I honestly,
Ira, that's why I love you so much, because I think of everybody that I've met in the ER space in my over 4.5 years. I think you and I, quite frankly, are about as close personality types as I've ever met. Seriously, and that's why you and I bonded from the moment that I met you.
Oh yeah,
it's an honor to have you with us tonight. And I could only imagine you putting you last in order was not a good thing to do to you. I do apologize to you for that.
No, but yeah, I'm like, I'll see you put me on sometime, I hope. I guess I'll just give you an introduction to me. I should probably, I'm leaving all the stuff on. I literally been searching. It's snowing here today. It is April 20th and it is snowing in Canada. Well, I mean, I'm the East Coast of Canada, but I'm sure the West Coast, I'm like central Toronto area, but I'm sure the rest of the country is snowing. It's nuts. Like I was riding a horse in the afternoon. It was beautiful. And then I came home and no, we don't all just ride horses. I like horses, but and then I lasted an hour and a half in clinic today. That's about all I can do for an injection clinic. I'm like, just put 10 patients and then an hour, I'm done. I can't do it. Then I went to ride the horse and then I came home and it started snowing. So I'm like, maybe I got skis. If I'm lucky, I'll be able to ski by the end. Anyway, hi, everybody. Dr. Ira Price. I have not been working as long as some people here. I'm in my 11th year of independent practice. And I work at a level 4 trauma center in Hamilton, Ontario, called Hamilton Health Sciences. It is affiliated with McMaster University, where I'm an assistant clinical professor. And we have 2 sites that we go between, the trauma center and the cancer center. Between the 2, and then 2 other small sites, we have about 200,000 visits a year between our sites. And I've been working with so I'm an emerg physician. I guess I'll start with that. I'm an emergency physician. Here you can do it 2 ways. You become a Royal College specialist. So I did it that way. I'm a Royal College specialist. Barry, you were talking about, when you started, there were 8 programs in the country. Well, we only have 8 programs in our entire country. For emergency medicine. My year, there was 32 of us in the country. And now it's starting to get a little bit bigger. Just that's how all residencies are here. They're small programs, hard to get into, and it's like a whole to-do. Anyway, I don't know why they took me, but they did. And then I did a fellowship in sports medicine, and I have a special interest in chronic pain, and I'm a coroner in our province, in the province of Ontario. So opioids are near and dear to my heart, and unfortunately, COVID has seen a 120% increase in opioid-related deaths here. And the fallout is just devastating. I would also, when it comes to cannabis, it's funny. I started in the day, I was almost like to the day that I got out of residency, my college started to dislike me. I went right into working with cannabinoids. And at that time, to be fair to the college, they had no idea what it was. Nobody really in our country was talking about it. It wasn't 1999. I mean, when I heard you say that, I was like, that's amazing. There were a few physicians that had dabbled previously, but nobody on a consistent basis. And And so 2010, when I finished residency, it was almost to the day where I was just frustrated already with seeing the early opioid crisis starting, and I needed to find something else. There was nobody in the country really doing it. So I started working with cannabinoids, and then basically had to teach myself. There was no real education at that time. There were some studies published, and there are some big researchers here in Canada, like Mark Ware, Mary Lynch, Fiona Campbell, and John Clark, all these folks at the time that were working with, but just in the research realm. I had to somehow bring it into the clinical realm. So I wrote dosing protocols that most physicians around here use, and started doing some research in it. And that brings me to cannabis hyperemesis syndrome. Let me share my screen. How about that? How about we start with that, right? Is that what I have to do here? I don't know why I sent my slides to you.
Don says, right, hit the screen share, right?
Share.
Yep, hit the screen share.
Yeah, right. Screen share. I didn't even see my whole damn computer.
Share.
All right, maybe this is it.
There it is. You got it.
You see it?
Yes, sir.
Winning. All right. Woohoo. All right. So this is cannabis hyperemesis syndrome for the emergency department. Now, the truth is, this is probably, of everything we see related to cannabis, which evidently is non-lethal in any way possible, this is probably the one thing we see the most of, and we increasingly see a lot of it. And so, I mean, we have 3 basic questions that I'm going to go through, and I have literally like 4 slides. And that's how do we identify it? How do we explain it to the patient? Because how do you tell somebody, sorry, cannabis, it's not your fault, but no more cannabis for you. And they're like, it's not the cannabis. It's for sure not that. So how do you explain it to them? And and my explanation, you may or may not like, but it works. And then how do we treat it in the emergency department? People were asking questions earlier on, what's the differential diagnosis for it and how do we move forward from it? Cannabis hyperemesis syndrome is the diagnosis of exclusion. Thankfully, cannabis hyperemesis syndrome sort of grew itself out of cyclical vomiting syndrome, and eventually a whole bunch of gastrointestinal disorders came together in one criteria called the Rome-4 criteria, and that's where cannabis hyperemesis syndrome was first identified. It was actually identified back in 2004, and updated in 2016, re-updated in 2018. The bottom line is, the first thing the emerge doc has to ask, and I think this is where most of them fail, to be frank, at least the ones who don't know about cannabis hyperemesis or don't understand cannabis in general. What came first, the chicken or the egg? If people started, if people were vomiting before they ever used cannabis, it's unlikely to be cannabis hyperemesis syndrome. A lot of people had turned to cannabis who had cyclical vomiting syndrome, and then started using cannabis, which helped relieve some of their vomiting, but still have episodes once or twice a year, come to the emerge, and now they're labeled with cannabis hyperemesis syndrome, where there was a clear distinction that the cannabis came after their vomiting. They already started vomiting. So we have to really make sure that we understand the cannabis, the chicken or the egg, what came first. And so in this case, we gotta, you really got to identify, was there an underlying, cyclical vomiting syndrome? Because I'll tell you, like, if you remember back in the early 2000s or even like the late 90s into, like, I would say probably until 2005, 2006, I never heard of cannabis hyperemesis syndrome. Everybody that presented was cyclical vomiting. We saw a ton of cyclical vomiting. Then it took like a 5 to 8 year hiatus where you didn't see any cyclical vomiters anymore. And then all of a sudden, everybody who came in was now labeled cannabis hyperemesis syndrome. So what is cannabis hyperemesis syndrome? How's it defined? So we basically, if you're going to use literature as our evidence, and I do agree that if you got to do meta-analysis, the reason we're supposed to do research is where we have a gap in knowledge, right? But yet everybody likes to go and do a whole lot of studies to common sense to like confirm what we already know. But anyways, so if we're going to use a study, we should use the Rome-4 criteria when it comes to diagnosing cannabis hyperemesis syndrome. And so what does it mean? So you've got to have, at least 3 months with, you've got to meet all the sort of criteria. What's crazy? I can't really see my slides even because I got a whole bunch of pictures of people. Oh, there we go. All right. I didn't even know which slide I was on. I'm just talking. Oh, that was great. Okay. I wasn't too bad. So the Rome 4 criteria, there it is. You must meet all the criteria for at least 3 months, and symptom onset for 6 months. So you don't have to have every symptom for 6 months, but you have to have some of these symptoms for 6 months, and it may be associated with pathological bathing. I'll tell you, for the most part, the pathognomonic part is, I take a warm shower, I take a hot bath, and it seems to get better. I haven't, and I never had cyclical vomiting until I started using cannabis. What I will tell you, and this is Sherry, I know Sherry had mentioned it earlier, where you see it mostly in patients who have chronically used cannabis for years and years. And, maybe the pathophysiology has to do with cannabis dysregulation in your body, knowing that cannabinoids are responsible for homeostasis. I've treated, I see 500 patients a month, and I've been doing it for a decade. So I've had hundreds of thousands of patient visits related to cannabis. And I've seen true cannabis hyperemesis syndrome twice, and both of those patients had recently started cannabis. So I think that I think the Rome criteria, which changed in 2018, took out the chronic cannabis use, where you can now get it. I mean, and I think you can, because if it's a dysregulation, it doesn't matter how much cannabis you use, it's not going to agree with you, and you're going to have that cyclical vomiting from it. So the initial criteria, aside from having it for that long, they were, did you get the cyclical vomiting? Did you present initially after prolonged cannabis use? And did the other pathognomonic thing about cannabis hyperemesis syndrome, which is awesome, is that it's relieved is with cessation of cannabis, which is awesome. Maybe not in the emergency department per se, but in life, it's just going to stop within 2 to 3 days of stopping cannabis.
Which, by the way, so I agree with you, it can happen new, old, but the 2 to 3 day thing is very interesting, because I've even been on chats with regular doctors, so to speak, and they're like convinced that it will go on for 4 to 6 weeks. And I'm like, no, it can't. If you are telling me that the patient has stopped, I am having a hard time believing it was cannabis related if they've stopped for 4 to 6 weeks and they are still having daily vomiting.
I haven't seen a study that showed it go on beyond 2 weeks, and most people were within a week, 2 to 3 days. You're good to go. Most people, as soon as you treat them in emergency, send them home. They may show up again, but then they're done. And you're pretty good as long as you can convince them to stop using cannabis. That's the hardest part. And how do you do that? I'll tell you how I do it.
Go ahead.
What do you do? Tell me what you do.
I send them to hightimes.com, because they won't believe me, but they'll believe the internet, and they'll believe a pot website, but not me.
I give them the bro talk. I'm like, bro, listen, cannabis is great. There's nothing wrong. Unfortunately, it sucks for you. You have an allergy. It's nothing you could do to. It's not an allergy, because it's definitely not IG mediated. But for them, it's akin to that. So if you can dissociate the cannabis from themselves, so you're not demonizing cannabis, because as soon as you take somebody who comes in with this stuff, you clearly know they enjoy cannabis for the most part, and that they're attached to it. They're really attached to it emotionally. So you got to take that emotional part out and not demonize cannabis. So they don't think that you just hate cannabis. Right. So I take that sort of away from us. Sucks to be you, but it's unfortunate. You are one of the unfortunate people that have something like an allergy. It's your body physiologically can't tolerate it. It's not you. It's not an emotional thing. It's your body. It's like how I explain anxiety to people. This is a physiological response when people don't want to understand, I'm not anxious. It's nothing you can control. It has nothing to do with you anymore. It's a physiological response, and it's like an allergy. That's sort of how I explain it to them.
Am I allowed to do the bro talk too? Can I do bro?
Yeah. I'll tell you why it's bro, because, when I give you the next slide in the study that I did, I think it was mostly men that had it. But to be fair, you tell anybody, yo, sister, it's whatever, or now it's whatever pronoun you want to use. And,
you have to say, hey, they.
Yeah, and sometimes I do. First I ask, how do you identify? That's like a thing in our hospital now. How do you identify? Which is cool. And so I'm like, how do you identify? Okay, this is what it is. So that's basically what I do. So what's the updated criteria for the Rome criteria? The updated criteria basically just takes out that it has to be a chronic, like a chronic cannabis use. It's just, you know, it's as long as you've used cannabis. And cannabis, I mean, I think the first criteria, which everybody seems to leave out, is you had no vomiting until you started using cannabis, right? Because that's like, I don't think there's like, if there was to be an inclusion criteria, did vomiting start, and the or exclusion criteria, did you ever vomit like just cyclically before you started using cannabis? And if the answer was no, then winning, you're included. If the answer was yes, right? No, did I say that backwards? Yeah, if the answer was yes, you were vomiting before you used cannabis, then you're excluded, because that's not cannabis hyperemesis syndrome anymore. That's just whatever else you have going on. So how does it look in an emergency department? Right, I have a pathophysiology. So what's the pathophysiology of cannabis hyperemesis syndrome? To be honest, like nobody is certain what the pathophysiology is. When you guys were talking about Haldol versus ondansetron in the treatment, and Haldol group did better, I mean, that may give us a little bit of an understanding that it's a dopamine receptor potentially, because Haldol works on dopamine D2 receptor, and as one thing. But nausea in general is super complex. Nausea is like part of your limbic system. It's part of your whatever medulla. Is it medulla, or it's something with an M? Yeah, anyway, I think maybe it is.
Your time is cutting short. Just keep.
Okay, fine. And cerebellar, like there's so many different parts that work to nausea, so it's difficult to really pinpoint what the pathophysiology. The bottom line is it's a dysregulation of your endocannabinoid system. So this study was done in the emergency department. This is the study that I supervised back in 2018 that we published. It was a retrospective study on presentations with cannabis hyperemesis syndrome. It was a 2-year multi-center study. And the bottom line is, so we looked at all comers with cyclical vomiting, and we looked how many patients did they mention cannabis with, like, in cannabis use. So could I say they met the Rome criteria? I can't really say that for certain, because we, at that time, nobody, like, you rarely saw any patient that literally mentioned anything, or a chart that said anything about what came first. All you would see is like marijuana use, because 2018 they were still using terms like marijuana use, weed or whatever it is. So but of that, we saw 494 cases of cyclical vomiting syndrome, and of that 19% of them mentioned cannabis. So you're looking at about 100 cases in a two-year time frame for people that presented with cannabis hyperemesis syndrome. Now, how are these people treated? Well, you can see here a whole bunch had blood work done, and intravenous fluid, different antiemetics, opioids. A lot of things in the beginning spoke about what's the difference between the antiemetic and opioids. Should we be using ondansetron? Should we be using morphine, fentanyl, Haldol? Like, what actually works for these people? And what is the differential diagnosis? Well, at the end of the day, the differential diagnosis is anything related to gastrointestinal disorder. Most likely, most common things in first presentation that you should rule out are pancreatitis, acute cholecystitis, gastritis, those very simple things that we can rule out pretty simply in the emergency department, either with simple blood work on first presentation or ultrasound. And so those would be your major differential, your differential diagnoses. So how do you treat it in the emergency setting? So this was the study you guys were talking about. It's called the HAVOC trial, and it was done recently, 2020. It was published, and I'll tell you, there are a couple limitations to the study. The first limitation is they had an N of 30. So it was a small trial, but it's like the only one we really have. The other limitation is that it was actually stopped early because of benefit. So they didn't complete it till the end, which in some ways is good, but in some ways you still stopped a trial before it ended. So I don't know. Up to you to decide. The bottom line is what was superior. So what they did was they took it was a triple blind study. They took Haldol and they took ondansetron, and they looked at the 2-hour mark, who did better. And at the end of the day, Haldol did better than ondansetron. It was Haldol plus fluids did better than ondansetron plus fluids. So I think we've thrown opioids out the window. You could use it if they have pain, but both pain and nausea seem to get better with ondansetron and fluids alone. I'm having my abdo pain starting to kick in as I talk about it. So I think if we're going to look at any trial, the Havoc trial, it was done. I didn't go through a whole PICO here. I'm not going to review the whole study because honestly, you could go to Journal Club for that. But the bottom line of the study is that Haldol was superior to ondansetron, and either one, whether you use 0.05 milligrams per kilogram or 0.1 milligram per kilogram, I wrote per kilometer. And so if you're running, sorry, ignore that. Thanks for picking that up, Barry. Yeah. Well, send me your slides. I sent the slides. Thanks. Anyway, and look, beanie. I wrote beanie, significant beanie instead of benefit. Just saying. All right. So I think that's all I have to say.
Ira, you're classic. I love every bit of it. And I love the perspective that you bring to everything. And once again, just, a fantastic night of presentations by everybody. I'll be honest with you. I had a whole chat segment, everybody. And I actually had Nikki Freed, our Florida Commissioner of Agriculture, chime in because I really wanted to direct a discussion tonight about anxiety, depression, wellness within our ER community of first responders and EMS and paramedics. I think what we need is a universal impairment scale, everybody, because what are you going to do with your ER doctor who works his ass off from 7 a.m. to 7 p.m.? He lives in Denver, Colorado, or another legal adult use state, or in fact, he may have his medical card, and then he goes home, has a lovely dinner with his partner, and then he's asleep by 10 o'clock at night for a wonderful, refreshing night's sleep, helped by his cannabis. And then he's at work at 7 in the morning the next day, ready to go, bright-eyed and bushy-tailed. He's going to test positive for THC, but of course, he's not impaired. What are you going to do if you have a 65 or so year old ER doc who's wearing a 1-to-1 patch for pain? Okay. He's not impaired, but he's using cannabinoids appropriately. So the next session that we do, everybody, I want to have a session focused on these licensure and job protection issues that I think are not just for doctors, but for lawyers, for social workers, for teachers, for cops, for everybody. Because it's 2021 today. And I think what we've heard about 2021 is that we've all gained the experience of our years in the ER to know that medicine and life itself is different in 2021 than it was when I started back in 1981. And if I don't learn those lessons as a clinician in 40 years of how best to utilize the last 30 years of my career, everybody, listen, I have a goal. I want to be 95-year-old medical cannabis clinician, okay, still working with the cane. I want to be the division director under the Department of Internal Medicine. I wanted to be the division director of the Department of Endocannabinoid Medicine at my local hospital. That's a 10-year project, everybody, and I know we can achieve it. And we achieve it by sticking together, educating, making sure that we as a cannabis clinician community, right, continue to join together for evenings such as this of education and advocacy. But my point is, I wanted to talk about Delta 8, right? And that what's going on right now. I wanted to, get from Ira what's going on with as legalization has come to Canada. How do we maintain our vigorous medical programs in our state, which we know need to have? I want to see how we can get ACEP and AAEM and other professional associations starting to stand up for cannabis as medicine and stand up for their providers to be able to utilize it appropriately as medicine, right? So my point is don't be surprised if I come at you again, everybody, to see if we can repeat this panel. And I'd love to make it a yearly thing. I see Steph once again. Thanks so much to Curely for sponsoring this evening.
Well,
And I would just love to be able to continue with the conversation as we go forward.
Absolutely. But there was one question. First of all, Dr. Price, I'm starving. Can I have some nuts? Second of all, there was one question in the chat that was never answered, and I don't know the answer, so I'm just going to put it out there if the person's still on. So they wanted to know, are there minor cannabinoids, not CBD or THC, that is a precaution or contraindication in specific populations? If anyone has a response to that. That was the only one that wasn't answered.
Not that we found yet, as far as I'm concerned. And I think when we look at the minor cannabinoids, it's going to be fascinating to see everybody up until Dr. Meshulam himself with EPM in Israel now coming up with synthetic cannabinoids that are also going to affect the endocannabinoid system. So I think, once again, Richard Nixon put the kibosh on the research of all cannabinoids. And I think that's what we're all waiting for, is for that legitimate research to be done. But to my knowledge, I don't know of one specific cannabinoid that's contraindicated in any specific condition.
Thank you. I just wanted to get that out there. Thanks for answering. And thank you, everybody, for a great night. And I hope we can all do this again real soon. And I'll let you finish, Dr.
We've done.
Well, listen, I don't want people
skiing.
hanging. Listen, it's 9:20. I appreciate everybody's attention for as long as it is. I surely am happy to continue to hang around and discuss those various issues that I really think are important. Like I said, I'll tell you one thing I am a little bit disappointed about. And listen, I'll be able to step back from being relentless on Twitter and Facebook. I was really hoping originally to have many, many, many more emergency medicine clinicians on tonight. And I think a part of it is the dysfunction that we had, unfortunately, with EM News. But I'll be honest with you, I still think that we're out here creating good trouble, everybody.
All right.
I just do. We're not mainstream yet. I reached out to the leaders of AAM. I reached out to the leaders of ACEP. I didn't even get an email back. So I think us attempting to do this with the utmost of integrity and honesty and enthusiasm, which we're going to continue to do every single day because of the passion that we all have, is still not met appropriately by those that are not in the means of creating the good trouble that we're creating. And, Sherry, you may want to comment it. You may not want to comment it. I'm not so sure that EM News, when they really took a deep breath and figured out what they had agreed to, was 100% behind us. I don't know.
So I'll tell you my impression of the situation very candidly is that emergency medicine news is not run by one individual. And the support that my column gets was a surprise that EM News even gave me a recurring column. And if you'll notice, it's a recurring column online, not a recurring column in print, which goes to show, I think, and this is the dynamic that we see everywhere, right? Is that we see some support in some areas and some lack of support or disagreement in other. And I think the important part here is to remember that 10 years ago, we would have never had this. 10 years ago, we wouldn't have even been allowed to get a print ad in that paper. And that, it's a good fight, and it's a fight that obviously we all are happy to do. And sorry, my dog is roughing at me in the background here. But it's really important to note that and value it and keep pushing forward, because I think even though it wasn't exactly what any of us were expecting or hoping, we still were able to reach out to, I think, 50 people here tonight.
You had 51 people. I don't know why you guys are upset about
Yeah.
not enough people.
I
started
over
here.
51 people on the chat at any given time, and consistent.
That's
Probably
huge.
about an hour and a half into it, we got down to about 35, 36. And there's been a lot of great student commentary and questions in the chat. So I do think, even though.
Sophia, you're exactly right. I think we're reaching out to the newer generation, and that's so important. And
were there students here?
There's students there,
like med students?
Yeah.
And
That's
I think
amazing.
amazing, right? And I've had
Students, residents, everybody.
Really, when I started, I had one person in the room, just me. I started talking to myself.
And can I
I'm
just
okay
say,
with that.
and can I just say, Dr. Gordon and panel, we didn't sponsor this to get 500 people. We sponsored this because of the education, whether it was just us speaking about it or whoever many people attended, didn't matter. It was that we keep fighting the fight. We keep going out and educating. And if it means that we get as many people, if not more, doing it ourselves than relying on the magazine or whatever, then that's the way we do it. It doesn't matter as long as we're out here educating, whether every one person is another person is another person. So please don't pay attention to the numbers. It's what we're doing.
and not just that, but to go based off of that, Stephanie, too, which was incredible and beautiful. And thank you so much for being our support for all of this. But also, I want it to be a place where someone who's curious, right, the curious, right, has a place and knows that there's people out there with, you know, good heads on their shoulders and, you know, is practicing reliable medicine and can hear all of our stories and see that it's reliable medicine. Because I think that's really what's also lacking in the space, is that it's overflowing with people spouting cannabis, right? Cannabis is healthy, you know, 420, great. But there's a general lack of somebody you can go to when you feel like you finally have that question, or when you finally make that breakthrough with a patient that comes in and starts confiding in you about their cannabis use and the positive outcomes they've had. And that's what I think this group is so valuable for, to just introducing ourselves to that community and to be able to have a place for people to come join or understand or get some more, you know, education on.
I just know I'm honored to have shared an evening with each and every one of you. And I surely want to offer to each of you anytime that I can assist in any educational effort in your zones. And I think each and every one of us on tonight feel that way. And so appreciative to the Society of Cannabis Clinicians and what you guys do. Ira, what you do, of course, up in Canada. Keep on doing it with great spirit. And David, I can't wait to get up to Oregon to visit you, because it's one of my favorite places in the world.
Right.
And Sophia, I look forward to seeing you very soon here in Florida.
You know, you should start one of those. What's that clubhouse thing? You should start one of your CC with the cannabis care things.
Well, for sure. Listen, we can arrange to do rooms. We can, and I wouldn't do them.
Yeah, just do this, because this is what people want to do. They just want to talk and answer. They just want, you know, people to answer questions and enough with the bro science. We've been dealing with bro science for like decade here, and I'm sure some of you have seen it for decades. And you know, I'm not pointing anyone out, but yeah, you did, like, you guys were standing on your shoulders to be able to do this, which is pretty cool. So
Even having conversations, we did a panel with women in cannabis. I don't know if Dr. King is still on, but the wonderful Dr. King was on our panel. And you know what everyone wanted to know? How to break the stigma, how to talk to your family about cannabis, how to talk to your kids about cannabis. It wasn't even on the endocannabinoid system or what dose or what this. It was like how to talk to your loved ones, how to get involved in the industry. So a lot of other things that were not just about the specifics of the endocannabinoid system.
I'm going to say one more plug for EMN. My next column is about sex and, you know, I love Janester Wilson King. Sorry, I totally butchered your name. Dr. Janester Wilson King does an amazing job on cannabis and female sexual orgasm. And I wrote a whole column about, hey, maybe it's time that we pay attention or discuss that whole aspect of life and how that is a great, guys, you guys have been doing that bro talk for decades and centuries, and us girls, we have not been doing that girl talk at all. But I will tell you that I am happy to announce that I purchased a bunch of topical vaginal THC lube for my girlfriends for Mother's Day. And I encourage that I literally wrote about that in my article. And I had to actually write one line after that said, do not buy it for somebody you don't know. It's sexual harassment. Do not do it to somebody who you think is, you know, I had to like write some like really specific aftermath to that, because whether or not we like it, physicians are not like, you know, unknown for predatory stuff like that. So I wanted to tell you guys that it'll be a funny article. Please
Check it out. Yeah, I did actually a really fun podcast, a really great podcast on cannabis and sex with brought on a friend of mine, Orgasmic Living, I think is which like house her handle or whatever. It's great. You can listen to that too. It's on what's the name of my podcast? The Higher Estate. I haven't podcasted since the beginning of COVID. So
I'm getting together with you. We got to get something going, man.
Let's do it. It's fun.
Right,
Listen, you guys shut me up for an hour and a half to listen to all this stuff. Like I got a lot of energy to, like, I haven't even worked out yet and it's 9:30. I'm going to go.
I was wondering what you're wearing on your head and all that. I haven't quite been able to figure it out. Those ski goggles. Yeah. Okay.
It's snowing here. So I figured I'd show you the, Canadian weather. It's snowing. I got a hat on.
Get a picture of that to that extent. Listen, everybody, I appreciate everybody's time. It's 9:30. I got my 35 patients tomorrow, and I'm going to be back in and doing my thing.
All right.
Thank you, everybody. Thank you, everybody who attended.
Thanks, guys.
Panel.
Thank you
will be hearing
all.
from me soon, and we will repeat it.
All right. Thank you, Barry.
Good night. Thanks, everybody.